So I had to deprogram that thinking.
Leave that as it is. So welcome back to the next episodes of Endoscopy Essentials, the second with Jacques Bergman. Welcome, Jacques. I hope everybody has listened to the first one, because that's the basis for the discussion now. Jacques, you are, of course, focused on Barrett and research and everything, but you have discovered a new topic, because it seems that you all of a sudden found out we might have been doing too much. So you have been lecturing and also in your practical work being involved with something which is called less is more. So maybe you can, at the start of this podcast, for those who are not so familiar, briefly summarize what that is. And it's a very Dutch thing, isn't it? And you're hoping it'll spread, hopefully spreading out. But please explain a little bit.
So this less is more concept kind of thing is, and I've not invented this stuff. The less is more line tends to stick to me personally now, at least within the field of endoscopy. But most of this stuff I've read and been inspired by others. There's basically, most things in my life there's a few things that I invented myself, and most of the things I've just created by opportunity or connecting dots. So less is more is about overutilization and reducing unnecessary care. It comes from me being increasingly frustrated by our endoscopy lists and our shortage actually of being able to take on patients, and then seeing what kind of patients actually end up on our endoscopy lists and thinking, why do we have to triage like 400 patients to fill these slots for 20? And then still end up with such crappy indications. The bottom line is that I think healthcare is good if you have symptoms, and healthcare is appropriate if something acute happens to you, if you break a leg or you get into a car crash or you get a myocardial infarction or you get a CVA or whatsoever. Healthcare is brilliant. I will seek healthcare when I have symptoms or when I get into trouble. The problem is, what do we do if we treat, survey, or screen for things that might be there, and are
or will come,
or might come, or and generally very unlikely will be there, or will unlikely come, or very unlikely will have consequences. The vast things that we do on our elective endoscopy lists are actually related to that. So that's screening for conditions, surveillance of post-polypectomy polyps, Barrett surveillance for intestinal metaplasia of the stomach, surveillance for dysplasia after IBD.
Or just scoping for vague symptoms where we know
for younger patients, exactly. So actually we do have strong data that it's useless. Or we have accepted it in guidelines based on expert opinion and absence of data. And these guidelines have followed up in each other and basically carried over time, and then it becomes like truth, whereas the underlying evidence is simply not there. And then these guidelines also tend to expand over time. So the diseases become bigger, never become smaller. And I also felt that in the scientific work that we do in Amsterdam, which is very much driven by technical innovation and what we can do, that it needed a counterbalance by something.
Mm-hmm. Especially in Barrett's.
Well, for sure, that was I actually said, how can I be frustrated about those shitty colonoscopy indications if I don't reflect on my own work?
Mm-hmm.
And then started reflecting on my own work. Actually, I realized that how I got into this business was basically treating patients. I was allowed to do my first endoscopic resections on patients that were too old and too frail to undergo surgery. So they had a small cancer diagnosed at the age of 90, and had cardiac and pulmonary comorbidity. The surgeons was just said, this guy will die if I take out his esophagus.
Even the surgeon said that.
Yeah, but probably less concerned about the patient. They say, well, something needs to be done. So they allowed this young guy, say, okay, you want to do, okay, now you do your endoscopic resection. So, and we did, and that allowed us to expand this. Now we will be treating a 50-year-old patient or 25-year-old patient. We will not be taking out his esophagus if he has cancer, and we can treat it endoscopically. But the only reason why I actually was allowed to enter this, to investigate this, is that we had a less invasive treatment for unnecessary disease. And later during my career, I started not treating those patients, realizing that they would more likely would die with their cancer than from their cancer. I sensed that, I felt that. And then I started basically having the guts to discuss that with the patient. Those patients knew that they had an esophageal cancer, stigmatizing disease. They will generally inflate that disease as something that they will die from immediately, because that's the connotation esophageal cancer has, and this is what you find if you go onto the internet and look for esophageal cancer information. So I had to deprogram that thinking and try to explain to them that I thought that they would die with their cancer, not from their cancer. And while doing that, I realized that presenting the facts to them was not bringing the message. So the real impact is if I would say to them, in all fairness, if you would be my father, and currently I'm at an age that I will more often have to say if you would be my brother, but if you would be my father, I would leave you alone. I'm convinced that I would be a bad doctor if actually I would be treating it. I can treat it, but it will come at the expense of a couple of things. Some of that is not something you should worry about, but really I would not do that for a relatively small cancer, because the stigmatizing effect of the cancer and the relative ease in which we could resect that, that's okay. But if I would have to do a very extensive resection, the patient would run into a stenosis that we would have to dilate for a disease that he would never get any symptoms from or die from. So then, after having done that a couple of times and logically discussing that with my team, we actually decided to take a different road in our endoscopic research. At that time, we had basically said, you do an endoscopic resection for a cancer, and then you ablate the residual Barrett's, because you don't want any cancers to come back. Treating the cancer was pretty obvious, and we didn't want to touch on that. But we actually moved away from ablating these patients.
Even that, because I thought the first step was your recent paper, you finish treatment and then you leave the patient alone, which is already a big step, because you found out, not unexpectedly, but somebody has to show it, that
you're right. That was
almost everybody dies from something else.
Yeah, so we with the network that we had in the Netherlands on a very homogeneous and joint protocol on how we treated these patients, endoscopic resection, subsequent ablations until complete eradication of the whole Barrett segment, and then following up these patients, having very few patients being lost to follow-up. We were sitting on high-quality long-term data. And so, and that's we investigated that, we published that, and then we started to look. The recurrence rate was so low, yet we were following up these patients on. The protocols were saying you need to follow them up every 3 months for the first year, and so we already had titrated that down, and then our results actually showed that the vast majority had a progression rate that was probably even lower than for non-dysplastic Barrett's, which we scope every 5 years. So we then started looking at what is actually driving if you should do that. So it's the chance of recurrence, and it's the competing risk. We actually also found out that our patients had a 40% higher chance of dying from unrelated disease than having anything happen in their esophagus. So then we said, okay, and actually if we don't scope them, and if we scope them, we find early recurrences, but these are asymptomatic. What would have happened if we would have waited for that to become symptomatic? if less than 5% has an early recurrence, how many of that 5% will actually go on and develop a symptomatic recurrence, whereas their competing risk of dying from something else is like 40 times higher? So then we started to look in that, and then actually we found out that we tried to quantify comorbidity. So we were looking into Charleston comorbidity indexes, and actually being able to see that if you would have a high score on that, for sure you should not do that. So that moved us away from following up or reducing follow-up. But in the same time period that we were doing that, we had switched gears also in terms of ablation.
Which, by the way, was one of the first questions I was confronted with. Why not only resecting and following, or yeah? And then at that time we said, there's a 30-40% risk of, but only dysplasia, etc., etc. Yeah, it's
that's the misconception there is that if, let's say, you have a 30% chance in 5 years' time, if you only take out the cancer, you have a 30% chance of getting metachronous lesions. If you will be following up these patients, you will be detecting those at an earlier stage than the lesion you initially treated. And so if you can save the patient from progressing to a more advanced lesion, the only thing that the patient, as long as the patient comes back, he will not die of esophageal cancer. He will always, if he gets a recurrence, majority of them will not get a recurrence, but if he gets a recurrence, he will pick it up in an early stage. And and I must admit there was also a scientific reason why we refrained from ablation. Because if you take out a cancer, you leave a Barrett segment behind, that's the Valhalla for biomarker-related studies.
Yes. Which Barrett
is.
So
if we want to have a tool that actually predicts if somebody would progress to a cancer, and you need enough events. So if only 1% of your patient progresses to cancer, how do you get enough data and tissue from a cohort like that? But this was an enriched cohort. So we again, with the Dutch network, we agreed that we would not ablate them. We would follow them up as we would otherwise be treating them. So generally every 3 months or every 6 months. And then we would biopsy them, and we would also brush them. And we would
look at them, of course.
Yeah, so start with imaging, logically. But they were in expert hands. So we knew that a visible abnormality generally would be picked up by them. And then if nothing there, it would be some of it might be picked up with the random biopsies, and we were doing the brushes. But the main focus of that was to collect tissue and actually develop a marker panel that we would then be able to take back into standard Barrett surveillance. And actually, we think that we're pretty close in doing that. And it also attaches to the role of non-endoscopic screening and surveillance.
But let's go back to the broader picture of less is more, because I think the questions could center around 3 areas. One is us, as doctors, as societies. Second is the patient, and third is economics. So the seemingly easiest is to start with us. I heard your lectures, and some of them were a frank attack on guidelines, because as you say, guidelines increase the disease. There are the wrong people sitting there. If you read through them, it's low evidence, low evidence, low evidence. So why do we have them? But there is such a tendency that guidelines get to the forefront. Most lectures consists of slides and slides and slides which cite the guidelines. That's a small counter movement. Do you think you will be successful, or?
You mean changing the guidelines and getting rid of that?
I mean, I'm always wondering, when there is nothing to say because there is no evidence, why do you have to sit down and say, we suggest this?
Well, I think we need to turn this around. If there's no evidence, we should not do it. Instead of, there's no evidence, but we're worried, so let's do something.
To the best of our knowledge.
Yes, but a lot of that knowledge we think is truth, but is actually carried over by previous guidelines, which are not based on knowledge, but on assumptions. And if assumptions lead to poor quality guideline advices, but these advices are copied over time, we tend to attach as much truth to that as to some of the real truths in medicine. And doctors in general, especially young doctors, they need some kind of guidance on how to manage patients, but most of that is actually how they should manage their own uncertainty. I don't really know what to do with this patient, so okay, where is the truth? Oh, it's in the guideline. So and they take what is in the guideline as truth.
And it all has legal implications.
Oh yeah,
so
absolutely. You're safeguarded if you stick to the guidelines.
Far-reaching.
So if you get sued or you get complaints, and you can basically show that you acted according to guidelines, then at least the doctors feel that they're in a safe zone. That's not what it should be. It should be, have you discussed the management with the patient, and has the patient understood what you are planning to do? You could do everything with a patient as long as you provided the patient with truth and given the full picture of it and have consent. So that means that but that requires that you invest time and that you reflect on what is actually appropriate to the patient. The easiest way out is just to take the guideline. What's in the guideline? Do that. You will say to the patient, that's in the guideline, we're going to do this. I don't think that for the important things in life, in terms of healthcare for patients that do not have symptoms, I don't think that's, most of the time what you do is totally inappropriate, but you're safeguarded by the guidelines.
Yeah, but the plea would then be withdraw from all that stuff and maybe have a chapter on what's known about ABC, and not have a guideline for every step in the management process. Huh?
Well, it starts with new guidelines and especially new diseases. So if we embrace new disease, we better be sure that disease really has some relevance to it. Or if we update the guidelines, if we would expand on the previous guidelines, I think it's time that we now critically reflect if there's really data that justify that, or are we following the same conservative reasoning from previous guidelines, which will require an enormous amount more money to have an incremental gain. So if you look at studies on treating hypertension, for instance, the first randomized study enrolled, I think, 80 patients in 2 arms. And the outcomes were like death and CVA. And I think the study was discontinued because of a massive effect. And the inclusion criteria for hypertension were like systolic blood pressure above 160 and diastolic blood pressure above 110. So then, oh boy, hypertension, if you treat it, that's good. And then subsequent studies going down on this, we're currently at 130 over 80, required thousands and thousands and thousands of patients to reach the same statistical significance level, but the reduction on impact was less. And we, as doctors, because our brains are probably not skilled enough to interpret these results, we interpret statistical significance as clinical relevance. But the incremental value of expanding guideline expansion, justifying that, is done, the impact of everything that we do becomes less. And the expense of what we need, the money that we need to put in to get that lower incremental value is going up more and more and more and more. So we need to counterbalance that because we can't put down the money for healthcare in none of our societies, no matter where, at least not in the industrialized world, we will be able to continue expanding on healthcare like we're doing. So we need to cut down on low value, low evidence in guidelines.
But that means we have to start with ourselves. We have to reduce the guidelines, to reduce the authority of guidelines, maybe more focus on what's really good evidence, of which there's not so much in endoscopy. There is. It's not so little, but it's much less. And also another aspect I wanted to mention when I listened to you, when you stage down and say we leave that as it is, at least for some time period, you need an even better research. And I take a closer look to make sure that you don't do anything harmful, correct or not? Or is that the same logical misconclusion?
So what we in Holland we're doing this for a couple of things. So we have a new Barrett's guideline. We rewritten the Barrett's guideline with the focus of reducing unnecessary care. So actually it's already we're starting the implementation process actually in the upcoming month, and we will stop Barrett surveillance for non-dysplastic Barretts less than 5 centimeters in length. And we will monitor...
Just stopping.
We stop. We tell the patient actually there's no value in doing that.
Age independent or somehow age dependent?
Yeah, so we logically discussed that. We say that below the age of 50, you can consider doing the endoscopies up until the age of 55, but above the age of 55, we should stop surveillance. Less than 5% of patients actually fit that age profile. So then 95% is all older than that. So that means stopping with low evidence, low value care and attaching an evaluation to it. So this is a healthcare evaluation process in which we will monitor the patients in whom we stop surveillance on the back-end side. So we will not be contacting them, but we will use cancer registries to pick up those who had a symptomatic esophageal cancer, and death registries to pick up those who have died from esophageal cancer. And it basically will tell us in 10 years' time how many of these patients actually had symptomatic cancer. That's the kind of disease state you want to prevent with surveillance. But we are implementing it now instead of investigating it for 10 years and then finding out that we should have stopped it 10 years ago. Now there's another way of what you can do with guidelines. Some of the stuff in guidelines, you can simply stop and agree that you don't need any evidence for that and that you don't need to monitor it. So that these are the two levels that we actually distinguish. So we have actually a list, we're creating a list in the Netherlands by inventories with like our knowledge agenda. We're like what do we think we actually are doing that is really ridiculous. We all agree that we should stop. We're not going to do any registration on that. We're simply going to stop without evidence. And that's the low-hanging fruit of getting rid of stuff that everybody is doing simply because it's in a guideline or for which there's no evidence.
Okay, so that was us. I mean, it's intellectually not so difficult.
No.
It might be painful, huge resistant, but at least if we are honest and think at least twice, it should be clear what we are going to do. So, the patient. It depends on whatever society expectations. Somebody comes, fear of cancer. Seems to be easier in the Netherlands and other countries. People would say, "Oh my God, you're not taking adequate care, and you're telling me I'm not worth to be surveyed," or what? How at least in your country, how are you dealing with that?
A lot of people ask me that. So when in 2018 we decided at that time, again it's about Barrett's, that we would stop Barrett surveillance above the age of 75. So a couple of us said we need a cutoff level. Not consider, just say above the age of 75 we will not survey you anymore because there's no incremental value. In fact, your Barrett's may have a higher rate of progression because you're getting older and senescence will have that you may actually develop dysplasia even at a higher rate than 10 years before that. But the chances that you will get to a symptomatic stage versus the cost that we have to spend simply do not justify doing it. So, okay, then we actually started communicating that to our patients. They buy it. There's a subgroup in our society of people that are worried about health, and that's a different topic. But the general patient, at least in my country, if you say, well, you've reached an age and we've screened your esophagus now at least once or multiple times, the chances that you will actually ever develop problems, you're better off without the surveillance. So there's like a relief in most of our patients. Oh, I hated
Do you give them figures or what? No. And saying risk A versus risk B, and one is 3%, the other one is 1%, or whatsoever?
Again, if you would be my father, if you would be my brother, I for sure would not survey you. If it would be my esophagus, I would not want to have an endoscopy. The chances that you die on your way to the hospital by being struck by lightning are higher than we will ever find something in your esophagus that will have an impact.
So it's kind of figures, because that's what's all about. Nowadays we talk about shared decision making. So you present the patient the evidence we are having or the likelihood, and not saying, if I was I would do the following, which patients often ask. So what's the best way? A mixture of both according to patient's personality? Are these long conversations?
Generally not. It's not that it's not only me having these talks, but also my nurse specialists. So the worry that we as doctors have, that we will create worry with our patients, or no, they will, if you will say you're done, and it's a matter of time, because if we don't survey these patients anymore, in 5 years' time, we will do an endoscopy, we will look at the Barretts, we will take random biopsies, and we will tell the patients, we checked your esophagus, there's nothing there, you don't need any follow-up. So it's the transition of something that we were doing in the past based on poor evidence and had low value, that we need to disconnect the patients from. But the amount of resistance from the patients against that, we overestimate. In general, that's if it just requires some connectivity, and virtually all the patients do that. Actually, in our implementation of our guideline, in which we will stop, we have actually a step-up process. So for the few patients that are really very, very worried, they can have a telephone consultation with the implementation team, and to explain in more detail why that is. We're not going to lose the battle on 1 or 2 patients that are so somatically fixated that for their quality of life it may be better if we survey them every 5 or every 10 years. But then we say, okay, well then we will scope you in 10 years' time.
But that the message to us in other countries would be tried out. Speak to your patients, maybe in a less patronizing way, and saying, to be sure we do this and that. Yeah. But leaving it open and try to lay the facts on the table and see what happens. Maybe you would be surprised, because most patients say, wonderful, goodbye.
Well, it also relates to, for instance, end-of-life cancer decisions that we make. So in our MDT and esophageal cancer, we have 2 of those every week, and we hammer down 20 patients in 1.5 hours. So they will, according to guidelines, will go on chemoradiotherapy or on chemotherapy, and then be followed up on surgery. And basically we just try to categorize them as quickly as possible, and then have them flow to the surgeon, to the radiotherapist, or whatsoever, and they will be communicating that we think that this is the best choice for them, and they will accept that, and they will follow down that route. In that process, and in my country, it's all about centralization, so the volumes are increasing, so it becomes like a kind of factory kind of thing, how we try to get every patient down the pipeline as efficiently as possible to reduce the time between diagnosis and first treatment. Actually, it's a quality parameter. I think there's no time for patients to reflect. And you would be surprised if you would ask many of these patients are at an age where they at least given end-of-life questions some thought. You should ask them. Mm-hmm. And so I'm very much in favor of using time that we actually save by stopping unnecessary care, to spend that time on having what we call the meaningful conversation with the patient. Okay, let's pause. Let's sink this in.
Scope less, talk more.
Yeah. Absolutely. That's a good one-liner. Yeah. The thing is, if you're paid less and you're paid for scoping, then doing cells and talking sucks. So that's a thing that we need to circumvene. But if you speak about meaningful care for your patients, I think, and then you would be surprised how many patients will actually refrain from treatment. The chances of a 80-year-old patient with a pancreatic cancer, resectable pancreatic cancer, getting back home to the same performance level as before his Whipple operation is less than 5%. And we're not telling that any of our 80 years old. There's not a single surgeon or a single gastroenterologist who actually says, the plan will be this. But in all fairness, this may be your only chance for cure, but here's the reality facts, and I'm worried. I'm worried that you're taking a decision because you are shocked by your diagnosis, and that we actually are doing what we do for all our patients without actually doing what might be right for you. Have you given this some thought? And you will be surprised how many patients will actually refrain.
Okay, I think we get the message. The third issue is economy. I mean, this is probably endless. But just one question: is it maybe in a more centralized healthcare system? Is that the only way to start? So if you have a super capitalistic system, let's not name any country, no chances there?
I think in any system, even in our Dutch healthcare system, the forces will be against driving this change. So the simplicity of, okay, if we reduce, like we stop Barrett surveillance, it saves us 50 million in 10 years' time. So give me 5 million a year so I can do better research, better treatment or whatsoever. That money goes, those cost savings go through different routes, and they don't end up on somebody's desk to be given away for making better healthcare. Even in my country, where there's where at least doctors and our system are more open-minded for actually being less commercially driven and production driven. So I think I've realized that the true change comes through the awareness of all doctors, that a lot of what they do is driven by uncertainty. They look for some kind of reassurance of what they should do, and they then stick to things that are considered to be true but not necessarily so, and you should actually weigh that, and doctors should be aware that if they stick to that per definition they are doing harm to the patient. So some surveillance and some screening may work, but all will do harm. So it's about awareness for people like you and me that actually we can refrain from guidelines or defer from guidelines if we weigh this in a proper way.
But if you make your living with screening, if you have an institute where you do this whole body MRI, the wellness MRI as I call it,
no, that if we want to tackle, that's what we need to tackle. So
but who is we? Who has to do that? Society, government, a dictator.
But it's about the somatic fixation of our societies and the carcinophobia of our societies. So if we are pushing things in the news that prostate cancer is something that we should pursue, and many men have prostate cancer. Actually, was in the news the other week in my country. Without a counterbalance of that, and it's way more difficult. It's way easier to scare people than to reassure them after they've been scared. So that's a difficult thing to battle. But otherwise, we will be investing money in early cancer blood tests that will worry our whole society, will exponentially drive healthcare costs, not only for the tests, but for the unnecessary investigations that it will bring, for the false positive findings that will have people be worried. People, not patients, but we've made them patients because they think that they now have a disease, but we can't find anything. But what's the reassurance if the blood test tells them? And then, so they will go through CT scans. There's not such a thing as a normal CT scan for a patient. So basically, health is a condition in which the person has not been properly investigated.
Exactly, that's an old joke, but true. Still.
Yeah.
True.
But if we boost that, and our society believes that anything we will detect has clinical relevance, because that's the layman's perspective to a medical finding, then we will drive consumption in healthcare to the max, and we'll get a very worried and frightened society. I don't know the way out, but it needs some counterbalance. That's important.
Okay, thank you very much first. I think this conversation showed that, when we listen to your lectures, it's an eye-opener and we say, we have to do something. But then, and that was I enjoyed it very much. What we did now is to show the complexity and what are the factors and what it needs. And if I understand you correctly, our preliminary conclusion would be let's start with ourselves, because that's what we can influence most.
That's absolutely true. By going this pathway as an interventional endoscopist, being focused on doing and acting and catching and wanting to tackle something, I realized that that's going to lead to frustration, and my message is going to fade away. So it's all about raising awareness on a personal level for doctors, that uncertainty in what should I do can actually drive them to do things that cause harm to their patients. And if they reflect on that and accept that that's simply the difficulty or the challenge or the beauty of our medical profession, then we might have a chance, at least on a personal level, to make a small change.
Yeah. Great. So think about what you are doing and speak to your patients. That's how we end this one.
It's a small wisdom, but very wise words. Thank you, Thomas.
Thank you very much. Thank you. And thank you for listening.